Hello, hello, I'm Dr. Fiona Hewe and welcome to the WHO Africa media briefing taking place in collaboration with the APO group. We start with some housekeeping. You can choose the language in which you'd like to hear the press conference by turning to the globe on the bottom right of your Zoom application and selecting your language. You will also have a chance to ask questions, and to do this, please use the question and answer function on your Zoom application, and remember that you'll need to provide us with a name and the news organization you represent to have your question answered.
Oui, bonjour à tous et merci de vous être joints à cette conférence de l'OMS. Si vous souhaitez écouter la conférence en français, merci de bien cliquer sur l'icône en forme de globe qui est située à droite de l'écran. Et si vous avez des questions, merci de bien vouloir préciser votre nom, le média que vous représentez, et merci encore.
Thank you very much. So now joining us from Brazzaville, Congo is Dr. Masiriso Moeti, the WHO Regional Director for Africa, to whom I will now hand over the floor to introduce our other panelists and also provide us with an update on the COVID-19 pandemic as well as other health emergencies facing the continent.
Thank you very much, Fiona. My warm greetings to our journalist colleagues and to everyone watching this press conference on the COVID-19 situation, particularly variants circulating in Africa. I'm very pleased to be joined for this conversation by first Professor Alan Christoffels, the director of the South African National Bioinformatics Institute, or SANBI, at the University of the Western Cape. SANBI is a key WHO collaborator in an exciting new initiative, which we'll tell you about. Welcome, Professor. It's my great pleasure also to be joined by and welcome Dr. Christian Happy, who is a professor of molecular biology and genomics and director at the Africa Center of Excellence for Genomics of Infectious Diseases at Redeemer University in Nigeria. Dr. Happy will update us on how variants are impacting the COVID-19 epidemic in Nigeria. A very warm welcome to you, Prof. And I'm certain we'll have a very good conversation about these very interesting themes. So the COVID-19 third wave in Africa has taken a downward slide with a 23%, so almost a quarter decrease in new cases last week, driven largely by countries in Northern and Southern Africa. That's the steepest drop in 8 weeks since the peak in July. This is an encouraging sign, but I think we can see that it's coming off a rather higher peak than the previous two waves. However, indeed, we are at still more than 165,000 new weekly cases, higher than the first wave's peak. This progress also comes with a stark reminder of the heavy toll COVID-19 has taken as we pass the sad milestone of 200,000 lives lost to the virus on the continent. Variants of concern, in particular the Delta, have sparked flare-ups, prolonging the acute phase of the third wave for longer than we had expected. This is creating challenges for the public health response, compounded by population fatigue, frankly, and difficulties people are having in adhering to personal preventive measures, especially where living and working conditions are crowded. In the past month, the Delta, which is linked to more severe COVID-19 cases, and with more people catching the virus, it's more transmissible, was detected, for example, in over 70% of the samples sequenced from Botswana, Malawi, and South Africa, and almost all samples from Zimbabwe, over 90%. Scientists are also tracking the C.1.2, a variant that's been found in 130 cases in 10 countries globally, including 5 African countries where more than 90% of the cases are occurring, mainly in South Africa. While the variant has some concerning mutations, there's no evidence yet that it is more transmissible, nor that it affects vaccine efficacy. And we will be learning more about this from the two professors. Knowing which variants are circulating and where is critical for informing effective response operations. This is why, together with SANBI, WHO in Africa is launching a new regional center of excellence for genomic surveillance in Cape Town. The center will help to scale up sequencing, and bioinformatics on the continent for COVID-19, and we are certain for other diseases. The continent lags far behind the rest of the world when it comes to sequencing, accounting for only 1% of over 3 million COVID-19 sequences conducted worldwide. So this groundbreaking initiative aims to initially support 14 Southern African countries to scale up their genomic sequencing by 15-fold each month. This analysis will shed light on what pathways COVID-19 is using to spread into communities. WHO is providing the project with more than an initial $4.5 million in the first 6 months, as well as with technical support. We're very excited about this partnership, and you'll hear more about this initiative from Professor Christoffels. On the vaccine front, in the past week, the COVAX facility has delivered over 5 million doses to African countries. I was saddened to read that 3 times as many doses have been thrown away in the United States alone, 15 million doses since March 2021. This is enough vaccines to cover everyone over 18 years in Liberia, Mauritania, and the Gambia, for example. Every dose is precious and has the potential to save a life. High-income countries have pledged to share 1 billion doses globally, and so far, 120 million doses have been released. Manufacturers are now producing 1.5 billion COVID vaccine doses globally each month, and 2 billion doses are required to reach 40% of people in every country. If producing countries and companies prioritize vaccine equity, this pandemic can be over quickly. But yesterday, the COVAX platform shipment forecasts for the rest of the year were revised downwards by 25%, in part because of the prioritization of bilateral deals over international solidarity. G20 health ministers have this week expressed their support for the global 40% vaccination target. This goodwill needs to be accompanied by concrete actions and financing for the global fight against COVID-19 to succeed. So I look forward to our conversation today, starting with what we're going to hear from my fellow panelists. And I thank you once again for having joined us.
Thank you, Dr. Moeti. Professor Alan Christoffels, could you tell us about the findings on the new variants in South Africa, particularly the C.1.2 variant and of course then the Delta variant?
Thanks very much for this opportunity. And I think it's important to point out that as a country, we are guided by reports coming out of our National Institute for Communicable Diseases, who has really been driving the country's response to this pandemic. And so if you look at the data that has been produced, and certainly the most recent data being released in early September, the Delta variant is by far the most prominent and accounting for nearly 95% of genomes in which that has been sequenced. If you compare this to what we had in May 2021, where the Beta variant was the predominant variant of SARS-CoV-2 that was prevalent within the country. And so you clearly see that there is a Delta variant that has been firmly established within South Africa. And I think one needs to also keep in mind that we have seen reports, and clearly we have been alerted to the C.1.2 variant. And I think it's important to point out, as has been echoed by the National Institute for Communicable Diseases, that the occurrence of this new mutated lineage occurs in less than 3% of SARS-CoV-2 genomes that have been sequenced. I think the public needs to realize that this variant is being constantly monitored, but at this stage, the numbers are quite low. And if we just look at the total genomes that the Genomic Surveillance Network in South Africa has sequenced, we're looking at a data set of about 600 or so genomes. And so among that, we've got less than 3% of genomes that have shown this new C.1.2 variant. And so at this stage, it is still early days. I think additional work will need to be done, and certainly more data needs to be collected in order to understand both the prevalence, but also the impact that this will have on the spread of COVID-19.
Thank you very much, Professor Christoph Hels. Now to you, Dr. Christian Happy, could you provide an update on the new variants in Nigeria, also particularly the C.1.2, if it is present, and the Delta, of course?
Yeah, thank you. I do think I want to confirm that we have not seen the C.1.2 variant in Nigeria, but it's also clear that from the month of July, when we identified the Delta variant in Nigeria, that has become the most predominant variant from all of the sample that we're sequencing in the country. So, but I also want to point out the fact that there is another variant, which is a variant under a variant of interest, which is the Eta variant, otherwise the B.1.525 variant that we discovered in Nigeria late last year in 2020. That is a most prevalent variant. It has mutations that are associated with potential vaccine escape and others. But then again, we say that, and if you look at that variant, it's really spread also very fast and the second largest variant in Africa. And it's also something that we're monitoring seriously because that's potentials, you know, like the Delta and like the Delta and then the Beta. And then the Alpha variant, I mean, especially the Delta and Beta variant for immune escape. So that's the situation at the moment. We know that Delta is actually dominating, you know, the third wave in Nigeria, and it is representing over 90% of the genome that we're sequencing right now. Over.
Thank you very much, Professor Happy. So now that we've heard from our panelists, it's your turn, dear journalists, to ask your questions. And remember, you can use the question and answer function on the Zoom application. But also remember, you will need to provide us with a name and news organization you represent. But also feel free to let us know if you would like to ask your question live, and we'll give you that opportunity. On hand, we also have Dr. Nixie Gumede, the regional virologist, Dr. Tieno Balde, the Deputy Incident Manager for the COVID-19 response, and Dr. Richard Mihigo, the Coordinator for Immunization and Vaccine Development Program, all based in WHO at the Regional Office for Africa. So now we will go to the first question. Vicky, are you ready to go live with your question? Vicky Mabota? All right, as we wait for Vicky to confirm, we shall go with the first question from Naftali.
Yeah, I'm sorry, I'm ready.
Go ahead, please.
Okay. So my name is Vicky from Caxton Eben in South Africa. And my question is around the vaccination and its safety for breastfeeding women and pregnant women. I recently received my first shot of Pfizer. And as before I got the shot, I told the nurse that I'm breastfeeding a 9-month-old son. And she said that I must then wait 5 days before breastfeeding again. I was afraid, I was not ready to stop breastfeeding, but 5 days was too long. It was going to win my son off. So I wanted to know, what is the difference? 5 days, waiting for 5 days, what happens after those 5 days? And when I went to the website, Department of Health, nothing about this 5 days. They were saying that we should go ahead breastfeeding. So my question is, if there's little research regarding breastfeeding mothers, pregnant women, and this vaccine, why was it then given a go ahead? Thank you.
Thanks, Vicky. That's a very good question, which I'll give to Dr. Moeti and then ask Dr. Mihigo to weigh in.
Yes, thank you very much, Vicky, for bringing up that question. There is no evidence that pregnant women and breastfeeding mothers are at risk if they take COVID-19 vaccinations. And I think you are reaffirming that because you haven't seen anything mentioned in the WHO website, and I'm sure it's the same in the information services of other technical agencies. So we think that you can go ahead and be vaccinated and continue to breastfeed your child. I think that this indication that you wait 5 days before you resume breastfeeding the baby is some sort of misinformation on the part of this healthcare worker, and we need to make sure that the right information is going out there as we are seeking to encourage people to get vaccinated. This is what we are doing currently in the region. Perhaps, Richard, you might have something to add on this.
No, absolutely not, Moeti. I think, Dr. Moeti, I think we have said it all. We are strongly encouraging women who are pregnant, but also are breastfeeding, to continue to breastfeed their children. We know all the advantage of breastfeeding, and we do agree with you. You can't wait 5 days, and we will make sure that the right information is uploaded on the website, because there is no such contraindication at all. Thank you.
Very good news indeed for breastfeeding mothers. Now our next question comes from Naftali Mwaura from Shinwa. And the question goes to you, Dr. Mihigo. I'll ask this to you. And the question is, are we on course to achieve the 10% COVID-19 vaccination target by the end of September? Are we on course as a continent?
Well, no, thank you very much, Fiona. We've heard the latest forecast that was provided by Dr. Moeti in her introductory remarks. As you know, we have that global objective of 10% of vaccinating all the population by the end of September. We are probably not going to meet that schedule, that milestone in the African continent. End of September, it's just two and a half weeks away, and we still have a lot of countries that have to catch up with that. So it's very unfortunate we are not going to get that, but the good news is that we are seeing more supply coming, and we hope that with the technical support that has been ramped up to support many countries, we can now working towards the 40% coverage by the end of the year.
Great. So now we go to the next question, still from Naftali with Shinwa, and this will come to you, Professor Christoffels, and then I will ask Dr. Gumede to also come in, giving us the regional view. So the question is, how serious is the threat of the new variant reported in South Africa? To you, Professor Alan Christoffels.
So I think, as I was pointing out earlier, I think we have to keep in mind that this is very early data. We're talking as much as about 100 or so genomes that reflect this particular variant. I think that is extremely small. And so in total, less than 3% of genomes that have been sequenced have had this variant. And so I think at this stage, I think that we just have to echo the NICD's word, and that it will be monitored closely, because keeping in mind that what you are looking at is whether or not it's going to increase transmissibility, and there's just no data for that. And I think we also, let's keep in mind that viruses evolve. And so while this particular variant has been highlighted in very low numbers, we should actually just wait and monitor this. And I think that would be the most appropriate response to have at this stage.
Thank you. Dr. Gumede?
Thank you so much, Fiona. And I don't want to add more to what Prof. Christopher has just mentioned here. I think there's still a need of a serious research and studies related to the C12 variant. But I think the public needs to know that so far, all the vaccines that are available are very effective to any type of a variant. So we are 100% sure that there'll be also a sort of a control to this C12 that has been identified to more than 130 cases in South Africa. And also not to fail to mention that this has been also identified in countries such as DRC, Mauritius, Botswana, as well as Zimbabwe. So there's quite a very close system that is taking place in all the countries to see what is going on as far as C12 variant is concerned. Over.
Thank you very much, Dr. Gumede. The next question comes to you, Dr. Mihigo, and then Dr. Maweti too. And it's from Marinella Corregia from All Manifesto. And it says several countries in sub-Saharan Africa still register very few deaths since the beginning of the pandemic, even if the vaccination rate in the countries is still really low. So why insist on a vaccination of 40% by end of 2021 and then 70% of the population? Is the balance between risk and benefit worth it? Please do not forget that rich countries, if they help for vaccines, they will then deny help for other emergencies. Or we can start with Dr. Moeti and Dr. Mihigo can weigh in.
Yeah. Yes, thank you. That's a good question. I think when we look at mortality rates, of course, we have to look at the number of people that have died directly from COVID-19, but we have to look well beyond that to estimate the impact of COVID-19 on health, on deaths, and on other aspects of life. And this is, in my view, what justifies the push to vaccinate people. So there have been estimates made, for example, that indeed it's partly probably the population structure in Africa. We have a youthful population. So the proportion of people who are in that elderly age group that is most vulnerable to severe illness and dying, and the proportion of people with the kind of conditions that make one susceptible to severe illness and death might be lower in Africa than in other countries. But it's been estimated that the economic impact of COVID-19, even before the economic impact, the precautions that have to be taken in order to control the pandemic have meant that some essential services for health, as well as other aspects of life, have had to be reduced in Africa severely. Immunization services, access to treatment for people living with HIV, prenatal care for pregnant mothers, even chronic care for people with the chronic diseases that make people vulnerable to serious illness with COVID-19. So all of this needs to be factored in. So it means we are probably going to see increases in illness and death from other conditions because of what has to happen and the volume of patients that have to be looked after in the systems. The economic impact to the fragile economies of the continent have meant that there are estimates that this impact will linger on for years in Africa, 2030 up to 2050. And if we have economic downturns, that comes all the way back to financing for health being reduced, impacts on health, including increased deaths. So we think that if the whole world gets vaccinated, it protects not only people in these African countries where we really want to stop the pandemic, stop the deaths and the wider impacts, but it also stops the emergence of variants which can go back to the very wealthy countries, which can then threaten everybody in the world. So the best deal is for all the countries to move at the same time to get as many people vaccinated as possible and to reach the kind of coverage levels that we're starting to see now in high-income countries.
Thank you. Dr. Mihigo, would you have
anything?
Well,
I think, no, on this comprehensive answer that have been given by Dr. Moeti, maybe I could just add a small element on the some of the points the journalists raised around the balance between the risk and benefit. I think we have now, after these several months rolling out of the vaccine, established a very quite strong basis of benefit from the vaccination. And the pharmacovigilance system that we've put in place, the monitoring of AFI, the adverse event following immunization is showing clearly that the benefit for this vaccine far outweighs the risk, which are very, very minimum. So I think we will really need to continue to advocate for people to get vaccinated because this is the only way we can get out of this pandemic, on top of all the different other dimensions that was very well explained by Dr. Moeti. Thank you, Fiona.
Thank you very much, Dr. Mihigo. Our next question comes from Diana Rapuk with Sante Canal Afrique, and it goes to you, Dr. Moeti. Is the vaccine shortage on the continent really a bigger problem than the vaccine hesitancy within the population?
Yes, that's a very good question. And the answer is yes, it is. In the earlier phases, there was quite significant levels of vaccine hesitancy for various reasons on the continent in some of the countries. But some surveys that have been carried out have shown that this has started to shift. As the vaccines have been rolled out, more and more people are interested now in getting vaccinated. There is still some work to do to help people understand, to minimize the vaccine hesitancy, vaccine misinformation. But at the moment, the big issue now, the big challenge is getting vaccine supplies. So in my view, we have to work comprehensively. Certainly, communities, individuals play a very big role in presenting themselves to be vaccinated, getting registered at the right time. And I think also bearing witness about having been vaccinated, showing the vaccine is safe and so on. But the problem at the moment to reach the kind of coverage levels that are needed really is around vaccine supplies. And of course, with the vaccine supplies should also be worked to make sure that the delivery capacity is ramped up.
All right. Okay, so we have another question now that is coming from Abdi Latif from the New York Times. Still comes to you, Dr. Moeti, and we can also ask Dr. Balde to weigh in. So it says, could you give us an update on the meningitis outbreak in the Democratic Republic of Congo? How concerned are you? And will the response to this meningitis epidemic impact the Congo's efforts to tackle other challenges, including the coronavirus pandemic?
Yes, thank you. This outbreak of meningitis just goes to underline the fact that on a day-to-day basis in Africa, we deal with many outbreaks of different diseases now in the context of the COVID-19 pandemic, and governments with our support are simply having to face up to this. So indeed, it is serious and it is a very big concern. It is an outbreak of meningitis in the Congo, in the northeastern Tsopo province, which has already caused 261 cases confirmed, and 129, almost 130 people have died. So almost half of the cases detected so far have died. And this will require both the government and the partners with WHO supporting to mount a strong response to this outbreak. So we are learning to simply add to the response to the COVID-19 other things, response to other hazards that appear, and also restoring health services, as I was saying earlier. This is, of course, a challenge to the capacity of the government. But we see also that the response to COVID, to other outbreaks, Ebola, is progressively building up the response capacities in countries. We're not starting from scratch. There have been people that are trained and the kind of systems for kicking into gear to respond to the pandemic, to an epidemic like this are being progressively developed. But there's no doubt it's going to add a challenge to the work that's being done on COVID-19 in the country.
All right, to you, Dr. Balde, if you have something to add.
Yeah, maybe just in addition to Dr. Moiti's point, it's about also, the importance of really building capacities at the subnational level. These meningitis outbreak is occurring in Chopo province, which is a bit far from Kinshasa. So definitely with some of the challenges related to the context. The accessibility in Chopo province today is really a major issue, both the geographic accessibility, but even the connectivity, the connection activities. But despite all of these different elements, I think there have been some capacities which has been built around all of these different, emergencies which this country has faced so far. And we know that at least, with the antibiogram that the germ which has been discovered, is quite sensitive to some of these medicine, the ceftriaxone. And currently the ICG is really working for the transportation, procurement and transportation of the ceftriaxone, for treating this patient. And the patient has been treated both at home, but also at the health facility. So it's quite a challenging element, but at least, building on what has been done so far, all of the system and the resources which has been made available and supported for supporting the country offices, I think we'll be able, to handle this one also, as all the emergencies. Thank you, and over.
Quite unfortunate, but we are glad to hear that there's capacity to handle all these as they come. So we have our next question from Elise Parker, which will go to you, Professor Christophels. And Elise Parker is with Radio Tigerberg and Newsflash. And it says, can you please explain which research will be done at the unit at the University of Western Cape in collaboration with WHO? And just as a reminder, journalists, please remember to give us the name of the media house to which you are affiliated.
Thanks very much. Thanks very much for that question. And I think it's important to just step back and understand that way back in August 2020, WHO Afro, together with the Africa CDC, announced a continental plan in how they were going to stand up support for enabling the continent in order to respond to infectious diseases generally, but also specifically COVID-19. And so the first phase of that strategy was really to mobilize resources across the continent so that we could have the kind of genomic sequencing that has been carried out, including by my colleague that is on this panel, Christian Happy. And so we've seen a successful rollout and continue to roll out the kind of resources that are needed in order to support the sequencing of these genomes. And in parallel to that, we've been applying our minds collectively to think through how do we then enable and provide the appropriate technical analytic support once all this data becomes available. And so while this is carried out in various sectors of the continent, the partnership that we have now established with the WHO Afro is really adding another piece to this puzzle in trying to support the analysis within countries so that they could best leverage the kind of training and also the kind of skills that have been grown across these months. And so the work that we will be doing at the University of the Western Cape is really standing up support for the SADC region initially as a start to dovetail with some of the other work that has been happening across the continent. And so, for example, we have been assisting various centers with understanding and also implementing analytical protocols for analyzing their data. But this will scale up. And so we are honing in on countries in the Southern African region right now with more hands-on assistance in order to assist them to carry out and also interpret the data that is being produced, with a view to keep in mind that we are busy building a skill set that has to go beyond COVID-19. We've heard this morning or this afternoon that there are many diseases that in fact plague the continent. And so how we respond to COVID-19, exploiting genomic technologies, is going to stand us in good stead as we apply them to many of the other diseases which we have to respond to.
Wow, interesting. This speaks about South Africa. Professor Happy, would you like to tell us more, to also tell us what needs to be done to support this research, especially in West Africa?
Yeah, thank you. I do think that WHO and Africa CDC, WHO and Africa CDC really, starting from last year, as Alan mentioned, set up, a network across the continent that was going to be using genomic data to support infectious disease, response to epidemic and outbreak in the continent. And the structure is well laid out. They have national lab, they have regional labs, and then they have reference labs. So Alan's lab, my lab, and then the lab in Cripps actually were the three reference laboratories. And I think that apart from Nigeria, these labs have done very well. I give you an instance. Recently, we've trained in our lab 14 different African countries on how to do genomic sequences. And the good news about it is the fact that some of the countries that we trained, like Rwanda, they went back to their countries and within a week, they were able to generate sequences on their own. And that has added a lot to the body of sequences that actually Africa has generated. Yes, Dr. Moeti mentioned the fact that, yes, we haven't produced that much, but we are way, way more better than what we were in the position where we were in 2014 or 2016 during the Ebola outbreak, where all of the work were done by by labs that came from outside parachute themselves in Africa and did all the work. But now we're taking charge of the situation. We're responding to the situation. We're identifying this variant. You could see the situation in South Africa. We're on top of it. We're identifying also new variants like you see in South Africa, in Nigeria, we identified. And I remind you, we have harnessed this technology to respond to this pandemic in Africa in an unprecedented manner. The first genome, of SARS-CoV-2 in Africa was done in my lab. And we did that in a speed that it remained unmatched, 48 hours. Then it shows that, look, that given the resources and then the necessary motivation, the support, Africa can rise to the occasion. We are at the point whereby, as Alan is talking, building the capacity that is going beyond COVID-19. We are also doing that. I mean, Alan is doing a whole lot of bioinformatics, which is a very great skill set that is needed on the continent. But we are providing hands-on training on next generation sequencing and also providing bioinformatics support. So we're working together and we're giving Africa the kind of skill set that it has never had before. Together, I can just tell you from the country that we trained recently, from Morocco to Tunisia, from Somalia to Ethiopia, crossing Africa, these countries alone have together generated over 2,500 genomes. And then this is just an output from training that you give people. And imagine if you spread it across the continent, then it means that, for every other epidemic that will be coming into the future, we would have set up a platform that will enable us to be on top of it and respond more effectively. We are not saying that we're going to change this thing overnight, but at least it's putting up in a position whereby we can leverage the resources on the ground, continue to build the capacity that is through the expertise that is available on the continent, and then we are actually preparing ourselves better for the next outbreaks and epidemics on the continent.
Wow, that sounds beyond the global solidarity. The continental solidarity is actually working. We are glad to hear that. Thank you very much, Professor Happy. And now we go to you, Rhoda Odhiambo, to go live with your question. Rhoda from BBC. All right, Rhoda, you will come next. I'll now go to a question from Esther Nakazi. Rhoda, are you
able to unmute?
Okay, go ahead.
I just wanted to ask Dr. Moeti, with COVAX announcing that it won't be able to meet its delivery targets this year due to the delayed regulatory approvals and manufacturing constraints, among other things, how many doses were African countries expecting to get through the scheme by the end of this year? And what impact will this have in Africa, seeing that vaccine supplies have just started picking up recently? And now the source where they were depending on getting these vaccines now says that they won't be able to meet the target.
Okay, thank you for that question, which is a very topical question today. I'll leave Dr. Mihigo to provide the exact numbers in terms of how many doses we were expecting. We were certainly expecting, I think we will obtain, and the supplies are starting to be delivered, more vaccine doses to start to pick up from now on until the end of the year. We have that 10% coverage target. But as you say, the challenges faced by COVAX really, including also prohibiting of exports by countries that were producing that now have had upticks, the introduction of the idea of booster doses by some countries that have already started to give booster doses really means at the end there has had to be a calculation, a projection that we will get 25% less doses than we were anticipating before the end of the year. So that simply means that the public health prevention measures have to be sustained at the individual level, even at the broader community level. You know, countries have to do what they've had to be doing as they've had an uptick in cases among mainly unvaccinated people and with severe illness, deaths, and the kind of overwhelming impact on the health system that we've seen in the third wave, that sometimes have to lock down locally and impose some restrictions on people gathering locally and continue to support and encourage the population to carry out the public health measures, masking, keeping a distance, and so on. It just means that those restrictions to a return to normal life have to be sustained. We've seen in the wealthier countries football matches, people going to restaurants, people going to museums, even people complaining and demonstrating because they're supposed to show a vaccine certificate before they can go into a museum, which just demonstrate that life is different. And we've particularly seen the number of deaths, the proportion of deaths drop drastically where immunization levels or vaccination levels are high in upper income countries. So it means we have to sustain prevention, work very hard to obtain vaccines, and really advocate strongly for the promises that have been made by wealthier countries, some of which are going into next year, to be brought forward. You know, it is urgent now to catch up in Africa in vaccinating countries. And we're hoping that countries that already have bilateral deals made, those that are storing vaccines that they are not yet using, there are wealthy countries with vaccine supplies reserved that are well beyond their population's needs. We're advocating for them to shift and provide these through COVAX to low-income countries so that they can have the opportunity to catch up. Richard.
Yeah, thank you, Dr. Moeti. We have done some projection to try to estimate the number of doses that will be needed to reach either the September 10% coverage or the December 40% coverage. So if we looked at the 10% coverage for September, we estimated around 274 million doses that will be needed. So if we looked at what has been so far delivered to Africa, which is around 148 million, and we have done some projection on what is going to be expected in this month of September, which will be around 80 million doses. Even to reach the 10% coverage by the end of September, we are going to fall short of 50 million doses. So by the end of the year, the projection has been to at least have around 920 million doses. And clearly, to get to that coverage, I think there will be a need really to ramp up the supply considerably. So 50 million doses that are going probably to be necessary to meet the target. And this is the projection that we have done. And the projection may even be a bit more wider when we consider the target towards the end of the year. So again, the advocacy, the necessity to prioritize supply for the African continent is become more than urgent. If at all, we have to also get to enjoy the normal life as we used to have it in the past, and the population going back to their normal. So we are very much concerned about the festivity around the holidays at the end of the year. So I think we need absolutely to make sure that people, vulnerable group, the most priority population are immunized before the end of the year. Over to you, Fiona.
Okay. So we have an interesting question for you, Dr. Balde, from Esther Nakazi, who is a freelance journalist from Uganda. And she's asking about the WHO's no regret policy. At what point is this effected, especially for Ebola? Doesn't it require concrete confirmation before resources are deployed by WHO? Shouldn't there be concrete evidence so WHO doesn't necessarily deploy the scarce resources? And this is in line with the Côte d'Ivoire situation.
Thank you, Fiona. This is quite an interesting question, but we just need to agree also this is a quite of process. I mean, the investigation and the confirmation of outbreak is quite a process. And in this process, I mean, it's really important to take action as quick as possible. And this is what has been done for WHO, by WHO and the different partners for Côte d'Ivoire, you know, for really trying to take the initial action, setting a team, and also trying at least, you know, to undertake the initial response activities which are really necessary. The no regret policy, I think we have seen that, I mean, this has been developed and implemented after the 2014-2016 outbreak, I mean, Ebola outbreak in West Africa, because as we also, I mean, the consequences of really somehow delaying some of the response actions. So this is really for trying, I mean, to mitigate all of the different consequences obviously the mobilization of the resources does not mean like we use them, all of them. I mean, when we take the decision of allocating, I mean, some of the funding and also mobilizing some of the resources, it was really to undertake the initial actions, but definitely the fund which were, I mean, mobilized by WHO, by different partners, were not entirely used. So I think this is a kind of, trade-off that we have to do. This is not exact science, but definitely given the role and the mandate of the World Health Organization, it's really critical to take preliminary action, for really trying to monitor and also to confirm, and also, I mean, to address these questions. Maybe Dr. Moeti might be able maybe to add some elements on this one, maybe if needed be. Thank you, and over.
Thank you, Balde. Dr. Moeti, do you want to add something on the no regrets policy?
Yes, briefly. I think that each circumstance determines what then gets done. So whether you wait for confirmation or whether you decide that the situation is very threatening and therefore it is wiser to swing into action. In this case, we had somebody who had traveled across from one country to the other, quite a long distance in public transport, in touch with many people, who ended up in a relatively crowded area in a big city, in Abidjan. So the risk of spread in such a circumstance in an urban area of Ebola was hugely great. I think this determined the degree to which the sort of no regrets need to start absolutely now, and the quick swing into action happened. It's true, it always needs to be weighed up, but we can sometimes just don't encounter ideal situation where the sequences goes as according to the SOPs. And it is better to take the precaution of taking action than waiting while there are delays in confirmation and then confronting a situation that's out of control.
Excellent. So now we have a question for you, Professor Happy, from Bart Mensing with ZDF German TV. And she's asking, what do you demand from the Western countries, pharmaceutical companies, to do to increase the African research on vaccines? How do you see the activities that EU undertakes in Dakar with Institut Pasteur to create vaccine production facilities in Africa?
Yeah, thank you. I do think that it's not just going to be action or that we're demanding from the European Union. I think it has to be something that will engage both the European Union and African government themselves. I think having to discuss with the Institut Pasteur in Dakar is not going to be sufficient for this whole continent. Africa is a continent of 1.3 billion people. Having one single platform for vaccine production, I don't think that is enough. We need more than that. And then it requires a concerted effort between African countries and government and WHO and developmental partners, and those donors, those donors that are willing to support Africa. I do believe that Africa do have the critical mass, do have the necessary brain resources to develop its own vaccine and then actually to push this to a point whereby a vaccine can be produced on the continent. We need several platforms, vaccine manufacturing platforms in Africa, and those manufacturing platforms should be able to provide for Africa. The question is that if you look back in the 80s, a lot of the vaccines were actually produced in Africa for diseases that were plaguing this continent. What happened after that? And I think it is a critical thing that we need to look inward and then start to see how do we revamp some of those platforms? How do we bring, both the intelligentsia in Africa, within the continent and in the diaspora, and then really set up and give ourselves a mandate, to start, producing vaccine on the continent. Because I strongly believe that the independence of Africa will come when Africa will start addressing its infectious disease problem. And this includes, ability to diagnose quickly, ability to develop vaccine and produce vaccines, ability to develop diagnostic and produce diagnostics on the continent. It is possible, it is feasible. What my suggestion is always that, yes, I do understand, but we don't have to wait and tender our hand and keep begging the European Union. But I think we have to come together. Africa can offer a lot. We have the brain resources. We also have some resources financially. It has to be a partnership where we can sit down and then set up our own priorities. Where do we want to do what? And who can do what on the continent, and work with partners in order to set this up. Thank you.
Indeed, Africa has a lot to offer. So the next question comes to you, Professor Alan Christoffels, and it's from Annelisa Kubeka with Daily News. And she says, 3 days ago, the Free State Department of Health detected the C.1.2 COVID-19 variant in 3 of the 5 districts of the province. Are there any further provinces in which it has been detected in South Africa? And then I'll ask you, Dr. Gumede, to also say something after Professor.
So yes, you actually rightfully point out that those were detected. I think we have to keep in mind about the numbers. We're talking about as low as 2 samples in a certain area, as much as 20 samples in another area. And so yes, across the country, we are seeing about 130 examples of this, and this is extremely low. And so rightfully so, it has been detected. But the levels are very low. And so at this stage, I think while it has certainly been detected in certain provinces, and I don't have the exact data with me right now as to which provinces, these numbers are extremely small in comparison to what we are sequencing. And so at this stage, I think it's really not a case for concern.
Dr. Gumede, thanks, Professor.
Yes, thank you, Fiona. Just to add on what Professor Allen has mentioned here, that when it comes to the numbers that has been reported, that the percentage is quite very low compared to what the numbers of Delta has been seen in the country. But to be quite specific, out of 9 provinces is a total of 5 provinces that has reported the C12. That is the Cape Town, also Eastern Cape, Free State, as the question has mentioned that, Gauteng, as well as KwaZulu-Natal. But that does not mean that the public or the people needs to panic up until we've got a very good scientific data that's going to be telling us the impact of this variant to deal with the outbreak that is taking place. So everybody is really requested that they really need to remain calm up until we've got all the evidence related to C12. Over to you, Fiona.
Thanks, Nixie. We have our next question from Matt Boswandole with FP in Kinshasa, coming to you, Dr. Moeti. And it says, since the beginning of the vaccine rollout on the continent, vaccination campaign in DRC doesn't seem to be taking off. For instance, one doesn't see the demand increasing, and even officials don't get this vaccine. How do we reverse this trend?
Yes, thank you. I think it's true that vaccine rejection, denial has been a strong feature of the response in the Democratic Republic of the Congo. The demand was so little that the country at some point had to redistribute some vaccine supplies that it had been provided for to other countries. So clearly, working with communities in order to help people to understand that the vaccine is something that is going to help them as individuals, help their communities, not only in terms of preventing severe illness and death, but also in ensuring that normal life resumes, the country's economy recovers, and other aspects of life are not negatively impacted by the pandemic. It really demands leadership, and leadership talking to the people and mobilizing and sending messages and listening to people's feelings, fears through networks of trusted communicators to people. So in addition to political leaders, technical experts, speaking to people through various ways, through the public media, it really means that we need to work through community leaders, networks of people, religious groups, religious leaders, other associations, trusted providers of the message, and also simplify the message, translate it from our sometimes technical jargon to address people in ways that they can translate, interpret, and internalize. And very importantly, we have to listen. There have been some surveys carried out. Why is it that people are not being vaccinated? What are they afraid of? What do they believe and work on improving and addressing that. We've established in WHO an infodemic response alliance where we are working with some social media companies that are tracking some of the messaging, and then where we are now reaching out to civil society groups, people who are in communication, in contact with people, to really send through the correct information. I believe we can also mobilize people who've already been vaccinated and have them testify their own experiences and be, if you like, models of something that it's required for people to. We've seen some people in other countries who have been vaccine denialists falling ill, some of them dying, and some coming out and encouraging other people in that, you know, this risk is real. I've been very severely affected. Please get vaccinated. We need all of this. But most importantly, we need to communicate with people to help them understand.
Thank you, Dr. Moeti. Indeed, a lot to do there. So we have a question from Christina Okelo with RFE. My question, and this question I'll give it to you, Dr. Mihigo. How do you respond to concerns from climate change activists? The climate activists that delegates from developing nations will not be able to attend the COP26 Climate Summit due to vaccine delays. And while at it, please remind us where Africa is in terms of its vaccination coverage.
Well, thank you, Fiona, and thanks, Christine. I think clearly the climate activist story is the expression of the frustration that we've seen for many parts of the continent. It's not only that particular group, but we remember recently with the Olympic Games where national teams had to travel to Japan, and special arrangement has to be made for the athletes to be able also to join other nations in the Olympic Games. I think it's a general concern that we are having in the region, which also will allow people to resume their life, to start travel without many restrictions, etc. So I think we can understand such frustration that has been largely delayed in many other areas on the continent. And I think the fact that we have been since several weeks now and months on this forum advocate really for more supply for the region. I think Dr. Moeti has been a champion in that area. So just to illustrate the level of coverage, as of today, the African region in Africa as a whole has received around 148 million doses only. And out of those 188 million doses, only 40 million people have received the 2 doses that are required to be fully vaccinated. So this represents merely 3% of the African population. And when you looked at sub-Saharan Africa, it's even worse. It's around 1.7%. So it's true that the situation varies from country to country. We have around 11, 12 countries that have reached a coverage beyond 10%. We have 5 to 7 countries that could potentially reach that. So you see these numbers still very low. It's less than 20 countries that could reach that level. So again, the need to increase the capacity of supply to the region is become more critical, particularly at this time.
Thank you, Richard. Then I'll give to you also the last question to you, Richard, from Sarah Jeving, who is with DEVEX, very good at numbers, I can see. So says, just to follow up on Rhoda's question vis-a-vis COVAX scaling down by 25%. So COVAX had previously said it would provide 520 million doses to the WHO Afro region by the end of the year. If it is 25% less, do we then anticipate 130 million less doses? And for the entire continent, beyond the WHO Afro region, 620 million were expected from COVAX by the end of the year. Are we now looking at 155 million less?
Yes, thank you, Fiona. Indeed, very good in numbers, and we are glad that she can keep this statistic that we regularly provide to the press. Yeah, I think as we have heard in the opening remark by Dr. Moeti, there have been yesterday with the announcement, the joint statement by COVAX, that the projected forecast that was done in July is going to be affected by the issues that she very well explained. So we are anticipating less doses than what was so far planned. It's true that the number will be reduced, but again, the only thing we can say at this stage, we need to be a bit more cautious about the numbers, because these things change quite considerably, and depending on the dynamic around the action that could be taken to mitigate such a reduction in the supply. We've heard the advocacy with the vaccine manufacturer to give preference to the COVAX facility over countries that have already immunized more people. We are hoping that we may see some change in the vaccine restriction that has been imposed in few countries. So if some of these points gets resolved, we may probably be in a different situation at the end of the year. But as we stand today, we are gearing up towards the reduction of the number of what was so far forecasted. But we need to continue to monitor this situation quite carefully and see how the dynamic will evolve over time.
All right, sounds quite fluid and changing all the time. So we are coming to the end of the virtual press conference, and let's turn to our three panelists and hear any final messages. I'll start with you, Professor Christian Happy, for 1 minute of your final message.
Yeah, thank you. I do think that Dr. Moeti probably has said it all. I think it's important for the world to come together and then make sure that, we all get the vaccines as soon as possible. And as much as possible, we should ensure that, everybody across the world is vaccinated. We in the field of genomics are seeing a lot. As long as there is transmission, there is a potential that we may be having new variants that are emerging. And that those new variants, some of them may occur and they may pose a terrible threat to the existing vaccine that have been developed. The rich nation should understand this, that as long as all of us are not safe, then nobody is safe. And as long as transmission is occurring, no matter where in the world, there is that potential that a very terrible variant may emerge that may undermine all of the effort that we've all put together as an international community over the past 1.5 years or 2 years, since this pandemic started. So we should come together as a global community and ensure that, we can put a stop to this pandemic as soon as possible. Otherwise, we may have to be dealing with a situation that is that may be more dangerous in the future. Over.
Excellent. Thank you very much. Now to you, Professor Alan Christoffels, for your last words.
Yeah, I think what we have realized in this pandemic and certainly previous ones is that building trust with communities is going to be essential. I think we're going to have to come together and ensure that both as scientists, as researchers, that we communicate what we do more clearly. We have to play our role in convincing people that there is a wealth of data out there that supports the safety of vaccines. There's a wealth of data that certainly shows that we have what it takes, certainly on the African continent, to respond the way we are. And we're encouraged to see that there is lots of discussion going on how does Africa develop its own vaccines. And I think having that capacity is going to be key for us to move forward. And that collectively, we have seen it, that there's much that we can do. Over.
Indeed, there's much that we can do. So, and finally, over to you, Dr. Moeti, and while you give your final remarks, I will give you a question from Janine, all the way from the core media in Iceland. And it says, how do you explain the downturn in the pandemic in Africa at this time? Is it because of restrictions in each country?
Yes, I think, well, we've had a third wave. We've had an upturn that's been more severe than what we had seen before. And then we are seeing now a downturn starting in all the three regions. So, but we still have some countries that are in a sort of upward trend. So, we've got 54 countries in Africa. So when we summarize all that, we are seeing an overall picture, but there's some variation in different countries depending on the key factors. vaccination, certainly in terms of serious illness and deaths, and also the degree to which restrictions are still being applied and the prevention measures are being practiced by population. So it all depends on that. We have seen fatigue. People are tired of wearing masks, keeping a distance. They need normal life to resume. There are clearly signs that of the need to re-emphasize and support people in keeping up these measures. But we've also seen governments becoming more data-based in terms of not carrying out the comprehensive national lockdowns, but targeting where the situation requires it, and then lifting these measures as a situation warrants it. So I think we need to sustain, unfortunately, we will need to sustain these measures longer than would have been the case if we had been able to acquire the vaccines needed in Africa. And in the end, it comes down to individuals as well as government taking strong action, working with partners. So to conclude, I'd like to again thank so much my two fellow panelists, Professors Happy and Professor Christophels, for the work that you are doing and for having joined us today. And then just conclude on the issue of working together across the continent, not only in terms of vaccine acquisition. The African Union has really provided the platform to bring countries together in a unique way, which has translated into action. And we are very keen in WHO to support that. We're keen to work with our scientists as well and leverage the capacities that we have had. And to finish on local manufacturing, this is something on which African countries tried to work very hard as we were going through a very painful phase in the HIV/AIDS epidemic to produce antiretroviral drugs locally. And I think there are many lessons to learn from that effort about partnership, the pharmaceutical companies, the kind of agreements that they reach with African countries, the role of governments where these companies are located, because they also play a role around issues like technology transfer, intellectual property protection. And very much I agree with Prof. Happy, African countries coming together, mobilizing the resources, mobilizing the partnerships, supporting the scientists, and bringing together those who can invest, because we also need investors, and creating a common market. One of the biggest problems is pricing. You know, we have 54 countries on our continent. We have to work to constitute a shared market. Pricing can be then favorable in order to deal with the competition from the big pharmaceutical companies that competed very severely in the area of producing antiretrovirals locally in Africa. Finally, thank you to our journalist colleagues for the work that you do to spread information around on the pandemic and on health in general. Thank you.
Again, thank you very much to our panelists, and again, thank you to our journalists. Indeed, to add on what Dr. Moeti has said, to appreciate you for coming out and getting the right information for the right reporting. Thank you very much. We are at the end of our virtual press conference. Have a great day ahead.
Thank you.